My name is Kelly Piper with the California Healthcare Foundation, and we're delighted that you're joining our webinar today. I'll give a few more seconds just to get people signed in, and then we'll get started. Welcome, everybody. Again, I'm Kelly Piper with the California Healthcare Foundation, and this series of webinars is related to our Opioid Coalitions Network. This group of counties across California are all working to lower overdose deaths and improve access to addiction treatment in their communities. Prescribing culture is local, and as I often say as a family doctor, we doctors are very difficult to change. We are slow to change, and certainly slow when others from the outside try and change what we do in the privacy of our own offices with a patient in front of us. So academic detailing is a really remarkable innovation that builds on how effective pharmaceutical detailing has proven to be. And for any skeptics in the audience, there are so many studies that prove we clinicians are influenced by pharmaceutical advertising, especially if that is done by someone we like and trust who comes to our office and talks to us face-to-face with just a few well-chosen articles. And interestingly enough, these studies show that all physicians believe that physicians in general are influenced by detailing, but we also all believe that we ourselves are completely immune to detailing, and our prescribing never changes. But of course, there's some great studies that show that it changes fairly immediately within a few weeks after the detailing. So when this technique was discovered for academic purposes, really to counteract overuse and to help physicians and other prescribers prescribe according to the evidence, it was really exciting to see some of the same impact. And Emily Behar and Philip Coffin in San Francisco have done some remarkable work related to opioid prescribing and naloxone using these very same techniques. I'm really delighted to invite Emily to talk about her research and what she's discovered and how those tools can be relevant to you as you do your work in local communities. And I just want to tell one quick story before we start, and then I'll go through some of this housekeeping. But those of you who are Atul Gawande fans may remember he wrote an article in the New Yorker that compared the use of ether in surgical anesthesia with the use of hand washing in surgery. And the interesting thing about ether is it solves the problem for the patient and the doctor immediately, because it turns out as a surgeon it's not very fun to operate on a patient when they have to be held down. Not so fun for the patient either. And so since this was an immediate problem solver for all, it spread across the world within 6 months of its demonstration in the US in the 1840s. Hand washing and antisepsis was discovered about the same time, and it turns out generations later we're still not that good at it. And the main difference is that hand washing adds more work for the provider immediately, and the harms are way downstream. So in other words, it may benefit the patient, it benefits the patient downstream, but it creates upfront work very different from ether. So opioid prescribing is very similar in that we've got to change how we prescribe, but it's very, very difficult to do. It adds upfront work, and the harm being done of our making the quick decision to give opioids when another alternative might be safer is way downstream. So very much more like hand washing than like ether, but again, there are so many things that we can do, and we're already making great progress, and I'm looking forward to having Emily describe her success. Just a few housekeeping things. We are going to mute everyone just for a pleasant webinar, but we encourage you to use the chat box and the question box. If you have a logistics issue, you can just chat to the host, but otherwise ask a question, use the chat box, and we'll both answer those during the presentation, and we may save some of them to the end. We are recording this session, so it'll be available within a week on our website. And again, we'll have plenty of time at the end to answer questions. So next slide. We do want to give you a heads up. Dr. Corey Waller, many of you know, a really engaging speaker, will be joining us in May for a webinar from 12:30 to 1:30 on May 18th on treating maternal opioid addiction. So please do stay tuned and register for that. All right, I'm going to turn it over to Emily.
All right, hello everyone. I hope that you can see my slides up here. Let's see, show my screen. All right, you now should be able to see my slides. Perfect. So thanks, Kelly, for the introduction. My name is Emily Behar. I work in the Substance Use Research Unit at the San Francisco Department of Public Health, and I also am a doctoral student at University of California, San Francisco in their Global Health Sciences program. I work with Dr. Philip Coffin, as Kelly mentioned, and together we've worked on a few different academic detailing-based interventions. So I first want to start us off by talking about a sort of broad overview of academic detailing, reviewing some of the historical concepts and some of the key aspects of detailing that hopefully will be useful in your own work. Then we'll go through sort of the nuts and bolts of the actual intervention, what to do in a detailing program, how to talk with providers, and then I'll review a case study that we did in San Francisco with the health department. I take that a lot of you are coming from different backgrounds and have a fairly wide range of experience with academic detailing and also with some of the more content-based aspects of this work around opioid stewardship initiatives. So I want to make this as broad as possible to begin with so that it's accessible for everybody, and then I will try and get into some of the aspects of the intervention that relate directly to opioid interventions, and we'll talk about that specifically in the case study, and then we'll have time for questions at the end where, if there's anything that I haven't touched on, we can review anything at that point or get into more of the sort of nitty-gritty specifics. So to get us started, academic detailing, Kelly did a great job sort of introducing the concept. It comes from the pharmaceutical industry, was birthed out of the concept that we need to be able to provide information in a digestible and readily accessible way for providers. The pharmaceutical industry has been very good at this and has done this for a long time. They, of course, have different incentives and so have refined a process that is very profit-driven and that they have data that, to show its success. While transferring that mechanism to academic detailing, there are, of course, certain differences. This is based on evidence-based educational outreach. We are not working with any financial incentives. But that being said, a lot of the core concepts that were used in pharmaceutical detailing are really useful to integrate into our work environments. So some of the main principles that we're going to talk about relate to the interactive nature of this educational outreach. So it's really important that academic detailing is based in a one-on-one interactive approach that's really focused on engaging the clinician, both engaging them in terms of the topics that interest them, but also engaging them in terms of understanding their experience. Like I said, it relies on digestible and visually stimulating information, and it's really important that it's engaging. So this is just another way to highlight some of the key differences between academia and the drug industry. So in a lot of ways, the goals are relatively similar. We want to be able to convey information and change behavior. Changing behavior is the bottom line of everything that we're focused in. However, the ways in which we have gone about this process have differed tremendously. So traditionally in academia, clinicians have to go seek out the information that they're looking for. They either have to stay up to speed on the journals that they're reading, or CMEs, sometimes require people to actually travel to trainings or, have trainings revolve around a system that's already in place. It's very didactic focused, it's text heavy, not necessarily visually engaging, data driven, and it doesn't engage the clinician's perspective. There's not great evaluation, and oftentimes the goals can be fairly unclear or unstated. The drug industry approaches this from a different perspective. they go to the clinicians. They make it as easy and accessible for clinicians as possible. So they'll find a time that works for them, and they'll travel to their offices. It's interactive. It's visually stimulating. It's still data-driven. So, that's not something that we will sacrifice in any iteration of the way we're conveying information to people. It engages the clinician's perspective, and of course, it's measuring outcomes all the time, and it has very explicit goals that are focused on behavior change. So before we get too far into detailing, I just want to remind everyone that it's something that takes a lot of time and a lot of practice. For those of you who have already been engaged in detailing interventions, this is something that you certainly will know by now. So it's something that not only takes time, but it also takes reflection. So, it's an iterative process, and after each detailing intervention, it's very important to sort of reflect on the process and think of ways that you can enhance the experience for providers as you go. So we're going to cover the basics of detailing. We're going to transition now to sort of the nuts and bolts, as I like to call it, of how to actually conduct a detailing session. I do want to remind you that if any of you are connected to each other or are part of programs that use numerous detailers, it's really important to be as communicative as possible with each other. From the detailing project that we did at the health department, both Philip Coffin and I were the detailers, and we detailed 40 primary care providers. And we were constantly touching base about our experiences. We employed different methods at times, and so it was useful to see, which method worked for each of us. It also helped us troubleshoot or, be able to build arguments in advance based on the feedback that the other detailer got from the providers that they were reaching out to. So I would really encourage you, if possible, to be in touch with other people that are conducting academic detailing, because I think it'll be a huge asset to be able to learn from each other. And the final reminder here is that detailing is in the details, and you'll hear me probably refer to this a number of times. It's the type of intervention where the very small things can be very impactful. The last thing that I want to bring to everyone's attention is, because detailing is something that is driven by interactions and by the commitment of the people that we're reaching out to, it's really important that we tailor-make the materials and conversations that we're providing to clinicians in a way that they will understand and it will be really accessible for them. So I like to show this slide because if you look on the left, this is the detailing brochure that we created at SFDPH when we were conducting a detailing intervention that was focused exclusively around encouraging providers to prescribe naloxone to patients that were on long-term opioids for chronic pain. And in some ways, it felt like we had to reinvent the wheel. There are a ton of materials out there that have been used in syringe exchange programs and community-based organizations for decades. They're effective. We know that, they convey the information we want, but they look really different. And so the three posters that I have here on the right-hand side of the page show you just some of the types of materials that we've used in the past. The information is not going to be so different, but we wanted a different visual approach. And so we made something that felt more sterile, that felt like it would fit in a clinician's office, and that we were making it as approachable as possible for the audience that we were intending to reach. So just something to think about. It's not just the visual aspect of it, it's also the way that you communicate, the language that we use is something that we should try and be as conscious as possible about how our audience is going to interpret what we are communicating to them, and what the ideal way is for them to hear the information that we're giving. So now I want to transition and talk about how we're actually detailing. So the first thing that we need to do is get in touch with people, right? In many ways, I think this can be the most challenging aspect of academic detailing. There are three main approaches that you can use. It will sound basic, but phone calls, emails, and in-person visits, they all have a set of pros and cons, and it's really going to depend on the circumstance that you're in. So phone calls, for instance, can be extremely useful. They don't take up too much time. You can ideally get a meeting on the calendar the first time that you make contact with somebody. But it can also be difficult because, from at least my personal experience anecdotally, I have found that receptionists, while they can be an ally, can also be a fairly substantial barrier. They are there to protect the clinicians and their time and their calendars, and getting past a receptionist can be a challenge. So, phone calls can be great, but they may not necessarily be the thing that's going to get you into every single office. Emails are a great alternative. When you're emailing, usually you can email directly to the provider, so that sort of takes out the middleman, which may prove to be a productive tactic. It also means that providers can respond at their leisure. This is good and bad. Providers can respond in the evening when they get home from work, but they also may never respond. So emails can sort of go into this abyss somewhere where you never hear back. But another positive aspect of emails is that you can actually begin a dialogue with clinicians before you ever enter their office. If somebody writes back and they're really interested in having you come in, you can continue that conversation and talk about, well, what are some of the things that you definitely want us to talk about? I can prepare some things in advance, or, there are a number of papers that I can bring for you. You by no means need to start this process at that point, but it's available when you aren't emailing. And then the last option is an in-person visit. This is by far the most labor-intensive. It requires a lot of time. It requires resources. But there are going to be some providers that you simply can't reach by any other means. And at that point, an in-person visit may end up being a good approach. It just depends on the circumstance that you're in, and it'll depend on the specific circumstance of the providers. One thing that I think is important to note here is the importance of tracking these process measures. So we tend to focus on tracking outcome measures, noting what happened during the intervention, but then also looking at data to see the impact of the intervention. But I think it's really important that we also track these administrative process measures as well for two reasons. One, it's very important for the field of detailing. Academic detailing has been around for about 2 decades, but it's still fairly new, and we don't know exactly what works in all circumstances. So if we are able to track the process of reaching providers at this stage, it will be really helpful because we'll be able to, ideally even publish some of that and understand what's working for people in different situations. I was reaching out to providers in an urban environment who were familiar with the organization that I was coming from, and reaching them by email may have proved to be really productive, and yet if somebody is working in a more rural context, it may be that in-person visit that's important. So I think it's important for the field for us to be tracking this. I also think it's important because we want to be able to have an iterative process during the intervention. If you're trying to reach 40 providers and you've made it through 10 and you're noticing that phone calls are not working, it's important to redirect your effort and maybe transition to more emails. So I think, as we're focused on data, let's also remember that it's important to focus on these early stages as well. So now we're getting into what you do when you finally get somebody on the line. You get them in an email or you get them on the phone. This is going to be the same thing that I will suggest you do when you also get into the office to actually start the detailing. But you want to make sure to be as concise as possible, but you also want to make sure you hit each one of these points. Who are you? Your name, your title, and a brief description of your background if that's something that they don't already know. Where you're from. So what agency are you working for? If it's relevant, disclose your funding source and your organizational background. And then what service are you providing? You should state why the sponsoring group has established the program. This is the rationale. This is where you're going to be able to get someone interested because you are showing the importance of what you're offering. And then the next step, when you show how they can benefit from it, is when you really can hook them. So you say, this is what I'm offering and this is why it's important to you. You know, this is what I think you will benefit from. And so those last 2 points are going to be really important. Of course, it's going to change depending on what topic you're detailing about, but since we are all in the realm of opioid stewardship interventions in some form or another, it's an issue that providers are interested in. It's also an issue that many providers are scared to talk about. And so this introduction becomes really important to show, you know, you're not alone. This is an issue that we are grappling with nationally. It's an issue that many clinicians are having to face and struggling with. And here's how I'm going to help you manage this difficult situation. So I don't think we have so much trouble with the hook because it's very present in providers' lives, but we have to make sure that they know we're not just here to commiserate with you, we're actually offering you something that's going to help you. This is an example of an email that we would send. And I wanted to show this for a few reasons. One, I want to point out a few key aspects that I think are important to highlight, and then also areas where you can switch things up. So right off the bat, the way you address somebody, the salutation can change depending on who you are and who you're talking to. It can be as casual as hi with the provider's name, or it can be something that is more formal, starting with dear. This sounds really basic, but when I said before that detailing is in the details, these are the types of things that we're not used to thinking about all the time, but that in this field of detailing all of a sudden become more important. So we want to make sure that, that from the get-go, we are reaching out to providers in a way that's really accessible and, you know, aligns our interests from the beginning. We decided to send emails all from Dr. Coffin's email address. And we did this for a few reasons. Number one, I am not a clinician, and perhaps I should have actually stated that earlier. As a quick background, I have a master's degree in medical anthropology, and as I said, I am currently a doctoral student. But I am not a clinician, and I'm not a pharmacist, and that can get in the way of detailing. It didn't prove to be an issue in the program that we had, but it was something that we were cautious about, and so we felt it was easier to just have these come from Philip. It gave a little more clout to our introduction. The other thing that was nice about using his email addresses is that Philip has 3 different affiliations. So he has an affiliation with UCSF, with CPMC, and with the San Francisco Health Department. And so we were very strategic about using his affiliations. And if we were contacting a provider who worked at UCSF, we used this email template. If we were contacting a provider who was part of the health department system, we would change that introduction sentence and write Philip's affiliation at DPH. So a small thing, but something to keep in mind, that you want to be as relatable as possible and as recognizable as possible to the providers that you're reaching out to. The second part of that sentence we included for everybody because this was where our research was coming out of. And then we went in with our opening sentence to explain exactly what we were doing, We're providing a service to providers through San Francisco around opioid safety, specifically the co-prescription of naloxone. That's it. We added this next sentence because a lot of providers were familiar with the previous co-prescribing program that we had set up, and so we wanted to include that, but frankly, you don't even need more than just your one introductory sentence there to explain what it is that you're doing. We thought it was very important to highlight that it was a one-on-one educational intervention. This was both to set expectations so that when we arrived at the clinic, a provider didn't have 15 people waiting for this meeting. So part of it was sort of level setting, but also to entice them so that they know, if I make time for this, I'm really going to get every question answered that I have, or, I don't have to listen to somebody else's questions. This is about me. We also included the length of time. So we went in saying that we wanted approximately 10 to 15 minutes. That may change based on your project, but try and be as realistic as possible. You want to make sure you're not over or undershooting because you want to make sure that the provider is making adequate time for you, and you also want them to make sure they know exactly what they're getting from the intervention. We remind them that we come to them and that we will give them materials so that they know they're not just getting education, but they're going to have some tangible things to look at once we leave. And we created materials specifically for this. Not everyone may have resources to do that. I will say, and I'll mention this again later, if our materials are useful in any way for anybody, they're available for all to use. But depending on your intervention, it may not be materials, but it may be the California Medical Board guidelines or the CDC guidelines, or it may be some articles that are really relevant to your topic that have come out recently. Whatever it is, it's nice to leave something for providers. And then we tell them how to contact us. And that's it. You want to keep it as simple and short as possible, and you want to make sure that they have more than one way to reach out to you. And then we get to transition to the actual visit. So hopefully that email that you sent or that phone call that you made will actually get you in. And once you're in, then we've got to figure out what to do at that point. So there are some logistics that, you have to make sure to know where you're going, how to get there, and leave plenty of time for the visit. It's not something that you want to fit into a tight day's schedule necessarily. There were many occasions where I went to detail for what I believed was going to be a 15-minute session. It's what the provider said he had time for, and then I would get there, and he or she halfway through would say, oh, I have so many more questions about this. Do you have more time? And then an hour later, I'd, finally be making my way out. So you want to be able to leave some buffer because this is an engaging topic, and a lot of providers are going to want to spend more time talking about it. Once you get there, you want to take in your surroundings. Try and use as much of that information as possible. What's the office dynamic like? What are the interactions like between the providers and the rest of the staff? Because for something like naloxone prescribing, providers can utilize their staff in different ways. So, maybe either some of the nurses that they work with can provide the education, or if there's a pharmacist on site, they can help provide information to patients. It just depends what the office setting is like. So really try and sort of take that in when you're there. Explain the purpose of your visit right away. That introduction slide that I showed of, who you are, what you're doing there, repeat all of that. Repeat it to the receptionist and the provider as soon as you get there. And be prepared to wait. So how do you engage with the provider? The very first thing that I think one should start with is asking how much time you have. That changes, even if you think you're going to have a certain amount of time, you get there and they say, actually, I'm really busy, I only have 10 minutes, or, oh, it's my lunch break, I've got an hour. Knowing how much time you have is going to set the agenda. So it's the most important thing to identify. And then you want to remember that the providers should really be the ones that are guiding the conversation. So try and make sure that you understand what they want to focus on. There are going to be a few points and concepts that you know you want to emphasize to everyone, and that's fine. That's expected. Either find a way to build it into the conversation you're having, or if it's really tangential, make sure you save time at the end so you can end, 5 or 10 minutes early and say, I'm glad we've talked through that. We can talk about that again, but before I leave, there are a few points that I definitely, want to convey to you. I like to lead in with one of two questions. Both of these questions are in the thought bubble on this slide. So I either start by saying, do you currently have patients on long-term opioids? Or I say, tell me about your patients on long-term opioids. Or I ask, what topics are you most interested in covering today related to managing your patient's pain or opioid prescribing? Now, for the intervention we did, I was there to talk about naloxone. And these may lead us down different paths, but it's important to know what the provider cares about. And then we can build in what we're talking about in a much larger context that they're invested in. Asking about their patients on long-term opioids, I thought was really important because it positioned the conversation in such a way that providers were already focused on their own patients. So it made it very personal. They're not talking about this in abstract anymore. They're actually picturing the patients that they have that are problematic or that they're struggling with. And as we move forward in the conversation, those patients are top of mind to them. So they're asking questions that are really specific and that hopefully have outcomes that they know they can implement and they know who they're going to focus on.
So Emily, before you go on, can you just go back to email? We had a good question, which is, how hard was it to get people to respond to the emails? And did you find that the emails from Philip worked fairly well? Or do you have any, could you review just a little bit more about challenges getting people's attention to even get that site visit arranged? Because it seems like that might be so difficult.
Absolutely. I'm sorry, I should have paused earlier to ask if there were any questions. I will, when we get to the case study part of this, which we should have time for, I'll go into some more details about what proved to be the most effective means of communication outreach. Emails worked pretty well. People were fairly responsive. We ran into issues where people's email addresses didn't exist, or we just wouldn't get any response, or we'd get a bounce back. So some of that is fairly inevitable, but I actually really liked the email approach. I think providers felt like they could digest our request and then respond at their own time instead of trying to, talk for 2 seconds while they're in the middle of running between patients to get something on the calendar. So I think emails can be very useful. And again, when we get to the case study portion, I'll tell you exactly, what percentage of our contacts came from emails versus phone calls. So I hope that is helpful. Any other questions while we're here?
I haven't seen any, so carry on and we'll get to the, to the case study. Oh, here's one, I'm sorry. How did you identify the practices to target for academic detailing?
So that I'll talk about. I'll save that actually until we get to the case study, because that's going to really, I'll tell you what we did, but that's going to depend very much on what type of intervention you're considering implementing and sort of what some barriers and criteria are around the project that you've developed. So that's a great question. I wrote it down, and I will make sure to answer it as soon as we get to the case study portion. And I'm sorry if this seems a little broad, but I'm sorry?
This sounds good. I think you can go on ahead, and we'll save the other questions for the case study.
Great. And, this at this point is a little broad because I'm trying to make sure that, that these are concepts we can build into our studies as they're all going to change and be different from one another. And when I get more into the specifics of what we did, I'll go into a bit more detail. So in terms of guiding conversation, again, one of the main points that I can stress here is that you can't go in with an agenda. You need to build that agenda along with the provider based on what their interests are going to be. And they may really differ from one provider to another. But there are ways that you can sort of adapt as you're working with the provider. So one tool that's really useful is using if-then clauses. So we don't want to just throw data at providers. We're not trying to give them a laundry list of facts that they should digest. We're trying to say, here is what we believe is useful, and this is why we think it matters. So, if you change this, then this will happen. And that is a useful way for providers to be able to put it into a broader context of what the actual results are going to be. And that should elicit more buy-in because they'll be able to really see the benefit of the things that we're suggesting. Barriers are going to come up all the time, and it's not a bad thing. What you want to do is try and be as prepared for objections and barriers as you can be. Part of that is just the more you detail on a specific topic, the more you start to see the patterns of issues that people have. Also, it's part of why I encourage you to talk to each other, because the more you see other people's barriers, the more you can start to anticipate what's going to come your way as you detail. It is something you can address in advance if you know there are certain things that are going to come up, but it's also important for providers to be able to have a safe space to say what their concerns are. They're going to want to be able to voice that, and it's important that we are prepared to really address those concerns in a thoughtful way instead of just, saying, no, that's not a problem, or, well, you're the only person who's brought up that issue, so you should, figure something else out with your clinic administration. It is something we want to be really respectful of and try and really give them that voice and then work through it together so that they feel like collaboratively they have overcome that barrier. In the same way, we want to manage objections just as we would barriers. And then in terms of closing, I think, the way we end sessions can be in some ways the most powerful. This is where we highlight the most important concepts that we discussed, and this is the space where you can actually get buy-in from providers. So this is where we need to make the big asks and have providers tell us what they're really planning to do. So, this is where, motivational interviewing techniques can come in handy. You can set goals with providers. If you are doing multiple detailing interventions, then you can, try and come up with a plan of what are they going to do between this session and the time that you come back, so that it's really top of mind and they have some concrete ideas of the way they're going to move forward. As you are going through the conversation, it's important to keep it as open-ended as possible when you ask questions. This is a tool that comes from motivational interviewing, but try and not ask questions that have yes-no answers. Try and ask questions that are going to be very conversationally driven. These are just some of the questions that we would ask. What are some of the challenges you face with your chronic pain patients? What types of opioid stewardship interventions are you most interested in? Which are you currently using? What do you hope to use? Questions that will elicit conversation right off the bat. And then we get into how we actually use the materials. So this is going to depend on what materials you have on hand. If you are using detailing materials, remember that you are using them to guide the conversation and facilitate conversation, but you do not want them to monopolize the conversation. The more you know the materials, the better off you'll be, because then you can, be immersed in conversation, and when you get to a barrier or an objection, you can say, oh, let me actually, I have some data on that. And then you can open up straight to the page that you want to focus on, review it, and then move on. You're not expected to know the answers to every question. There are times where you're just going to have to say, let me get back to you. Let me see where that data is. But ideally, you'll have a good amount of support in the materials that you bring, and you can use the materials to help you make your point, to bolster the point that you're trying to make. Most critically, I will say, do not give your materials away until you have finished your session. I have learned this the hard way. The second your materials get into a provider's hand, you are no longer in charge of this session, and the provider is listening to you with one ear and reading the materials, at the same time, and they're not focused, and it's going to be much harder for you to maintain that stream of communication. So hold the materials yourself. Again, this is a minor detail, but I really think it matters. Use it as much as you want, as much as is useful in the session, but just your hand is the hand that's on it, not theirs. And then at the end, you can give it to them. And of course, they can always call you or email you if, as they've reviewed it, they have any questions that arise. So there to sort of circle back to managing difficult conversations, and there are different ways that you're going to run into barriers. And those of you who have been detailing, I am sure you have run into one or all of these issues at some point or another. We can handle them all somewhat differently. So the first is stops, and this is where you really just hit a wall. I have found that this happens typically at the beginning of my session. It usually is built off of the rationale. And so for those folks, you need to back up, and you may need to do some big picture discussions. So, I can't get into naloxone, the details of prescribing naloxone if somebody doesn't have any buy-in and they're just, gate closed at the beginning. And so then we've got to circle back to the contextualization, what's going on nationally, referring to the national epidemic and talking about some of the issues that we are having related to opioid use disorder and getting buy-in that way. If there is a stop, it's important to know what causes that. So it's usually either the rationale or it's somebody thinking, this is not feasible for me to implement. And so try and figure out which the stop is and then guide it that way. As I said, it tended to be rationale for me, but if it is more logistics-based, that's okay too. You just focus on the logistics. A stall is where somebody, is kind of interested, but I'll get back to you in a week. That sounds good. Let me talk to somebody else and I'll let you know. And stalls can be tricky because there's sort of an ambivalence to it. And I think the importance of that is making everything that you are conveying feel really accessible. Stalls, I think, tend to come from people feeling like there's going to be a lot of burden or labor. They get the idea, they're on board, but do we want to implement another thing in the clinic? And so that's where they want to, talk to somebody else or spend some time thinking about it. And so the more that you can, the easier you can make this feel to implement, the better off you're going to be getting past the stall. On the fence, this is somewhat similar to a stop. It's somebody who, may be interested, but they're not sure either if they support the ideas that you're putting forth or if they themselves feel like they want to be the ones involved in this. And so it's important when somebody's on the fence, more than likely to go back to the rationale building again and make sure that they really have that conviction, that buy-in. They understand the importance of why they have to be the change agent in the field. And then indifference. And indifference is, this sort of complacency can be hard to manage because we are asking something of a provider. And so what you may want to do is try thinking of a different ask. If they're indifferent to the one that you initially present, find out what they're not indifferent to and change the ask. So you don't want to get off target, but there are different ways that you can build an approach. This is the last slide here, and then I will quickly get into data from our experience. So this is just about, what do you do after the visit? So try and track all of the information that you can. How long were the visits? What topics did you cover? What questions did they ask? The questions is important to build in because I would always review those questions and start including them in the detailing sessions that I did afterwards. Follow-up, this totally depends on the intervention that you are conducting. So, you may be doing a one-off detailing intervention. This may not, be as useful if that's the case. If you have multiple meetings with somebody, try and plan that next visit while you're there. You already have their attention. They've had a good session. They've learned a lot. Get the next appointment on the books. And then, as we mentioned before, try and build in a hook based on that time period. So, do they want to prescribe naloxone to 5 of their patients between now and the time you come back? Maybe. Do they want to prescribe it to 1? Maybe. But try and use that time to build in some motivating action that they're going to actually be able to act on. And then, circle back to them if they have asked questions that you can't answer, or if there's information that you want to send them based on the conversation, stay engaged with the provider. Okay, so I guess this is a good time. Kelly, if there are any other questions that came in, I'm happy to take them now, and then I'll quickly spend the next, let's see, 6 minutes on our experience.
Great. So why don't you address how you selected the clinicians and maybe a word or two on engaging, and if you think it matters, you have to be a clinician to do this work. Obviously you aren't, but is there any benefit to having a clinical person versus non-clinical?
Yeah, great. So this, as I mentioned before, is an academic detailing intervention that we did in the San Francisco Department of Public Health. And this was around naloxone co-prescribing. So in terms of how we decided who to target, this is the eligibility criteria. It's very broad. We wanted primary care providers who were still practicing, outpatient. We included a few subspecialties because they were providing essentially primary care services to providers, to patients. And this is based on the project that we came up with. It was specific in certain ways. So we did not include any primary care providers that were part of the San Francisco safety net system. That's because we had already conducted a naloxone intervention with those providers. And so there's no reason other than that we wouldn't have included them. If we hadn't done that previous project, we definitely would have included them and had it been any primary care provider. The last point of eligibility here is that the providers had to prescribe opioids to Medi-Cal patients. This is because of the way we planned to access data for the analysis. So again, there is no reason aside from the analysis plan that we developed. However, this is actually an issue that many people will run into. We don't have access to cures data. It's very difficult to know what prescriptions providers are writing. So, we were able to get access to prescriptions that were written to Medi-Cal patients, and so that's why we chose the providers that we did. We had a list of providers that prescribed to Medi-Cal patients. We randomized that list and started calling providers that way. We randomized it only so we'd have some point of comparison between providers who did receive the intervention and those that did not. So essentially, aside from the specifics of our study design, it was really open to any primary care providers. So now, in terms of how we made contact with people, so phone calls and emails were our strongest sources of contact. We ended up actually reaching more providers by phone calls than by email. Our goal was to detail 40 providers, so we ended up contacting 46 because 3 were not interested and 3 were too busy. And sorry, something I didn't mention before but was on this slide is that MDs, DOs, NPs, and PAs were all eligible. So anybody that could prescribe to patients. So the number of contact attempts. So we reached 20% of providers on first attempt, which was great. And I hope that you are reaching at least 20, if not more, on your first attempt, because it will make your lives more sane. Most of the time, it took 2 to 3 attempts, and that's fine. That was not terribly burdensome. Once you start to get into the 4 and 5 attempts is where it starts to get really difficult. And I would suggest that you have a cutoff that is set in advance, where you say, if we've made 5 attempts to a provider in email, phone calls, then we, in person, whatever, then we'll stop and we'll move on. Detailing, the mean duration of detailing was 28 minutes. This was not always what we had prepared for. There were many occasions where I went in for a 15-minute meeting and an hour later had actually finished the intervention. So, it's why I say include that buffer time. But a 30-minute intervention it's a nice amount of time to be able to really talk with providers. For us, the most common topics were indications for prescribing, who to prescribe to, and how to prescribe, language that we used around prescribing, which I'll get to on the next slide, and examples of how to prescribe. This is going to differ depending on where you are and what the context is. I wanted to show this because this is something that was really important for us. We had done a number of interviews with patients who had received naloxone, and we were asking questions about their experience with overdose. Have you ever overdosed? And we were getting, no, I haven't. But we realized that the terminology we were using was not actually being received the way we intended for it to be received from the patients. So this is a quote that I really like, because I think it exemplifies this. I had asked this person if they had overdosed, and they had flat out said no, they had not ever overdosed in their life. And then they were talking about these bouts of delirium. And they said, well, I've had these bouts of delirium. I said, how many times have you had this? 8 to 10 times. How many times has naloxone been used on you? 12 to 15 times, all because they haven't been breathing because of their opioids. This person did not identify this experience as an overdose, and many other people didn't as well. Overdose, you can't overdose when your provider gives you these medications. Only junkies overdose. We would hear things like that over and over again. And so what we realized was it was really important that we convey to providers that they need to communicate in a way that's going to make sense to their patients. And so we've actually really encouraged providers not to use the word overdose if they can, either to say accidental overdose or to say bad reaction and then explain what that bad reaction is, so that it's sensitive to the patient and they can really have a dialogue that makes sense to both the patient and the provider. There are limitations to our study. Geographic scope is certainly one. In terms of the generalizability, we did this in San Francisco. It's a very different environment than many other communities. Geographic scope is also a limitation because we've got to travel. And so depending on where you are, it may be really difficult to reach providers. As I said, accessing data is difficult, and the time and resource that it takes to produce a detailing intervention is difficult as well. Sorry, I'm going fast. I'm just trying to wrap this up quickly. But 58% of the 19 providers that we reached during follow-up had prescribed naloxone. We were not able to reach everybody. Again, like I said, it turned out that providers had, they had patients on Medi-Cal, but that was actually a small percentage of providers' patient pool. And so we called providers to find out if they had prescribed naloxone, and were able to reach 19 of them. So academic detailing can be successfully delivered to primary care providers. I'm really excited to learn more about how successful the intervention can be in different contexts and different geographic areas. One thing that Kelly asked that I will quickly bring up is whether or not detailers need to be clinicians. So we had initially started the intervention having only clinicians detailing. Before we ever got in the field, for various reasons, we decided that I was actually going to take over, and so Philip and I detailed together. from the responses that we got from providers, it didn't seem like the experience was different if it was Philip or if it was myself detailing. I think the most important thing is that you have interpersonal skills and can really, openly have a dialogue with a provider, and that you know what you're talking about. So it doesn't need to be a pharmacist or a clinician, but it does need to be somebody who really knows the material well and who's worked extensively around these topic areas. And I think it's okay. I think probably it would be better if it's a provider, but I didn't feel like it ended up being a barrier in our intervention.
Well, Emily, thanks so much. And I do want to say that it was so impressive, the results that you have obtained, that 47% drop in people going to the emergency room for opioid-related reasons if they had been prescribed naloxone in this intervention. And that was so impressive that the California Department of Public Health hired Emily and Philip to train detailers in 3 northern counties. So that's happening in just within less than 2 weeks. They're going to be training physicians and pharmacists just under that understanding that sometimes physicians are more likely to listen to physicians, but certainly we'll find out if that is true. And just one last comment, if any of you is interested in learning more about the power of detailing, Adrienne Few Berman, who directs this organization called Farmed Out in DC, gives it just a fantastic TED Talk and also a lecture on YouTube that you can go listen to about the specific techniques that pharmaceutical companies use, and then, of course, that academic detailers can borrow. So I don't see any other. Go ahead, please.
I would just add really quickly something that I forgot to mention. Another fantastic resource is NARCAD, which is the National Resource Center for Academic Detailing. They are a group that has sort of been nationally at the forefront of academic detailing interventions, and they've got wonderful resources on their website. They have slide decks and sample materials, so it's another great resource for people to look at.
Wonderful. We'll give a couple minutes to see if there's any other questions, but while we're waiting, I just was wondering if you ever felt intimidated. How did you deal with your own feelings of getting past the initial rebuff, which I imagine is the first yes?
Great question. So the answer is yes, definitely. There were many occasions where I would feel intimidated, and frankly that there were situations where Philip did too. There are some providers that are just going to blow you off from the very second you walk in. And so, of course, it is important not to take it personally, but also to try and really think on your feet as fast as you can and figure out, first, to know when you're just not going to get in. I think that's important. There are certain situations where it's just not worth your time. But if you can work through a situation with a provider to, make sure that they feel like they're really getting something out of this, you are here for them. They're not doing you a favor by giving you their time. You're here because you think you can offer them something. And making sure that they really know that so that they don't feel like this is, such a burden. Because you know what? If we don't have to give this education to them, we can give it to somebody else. And so I think that was helpful to frame things in a way so that the providers felt like we were offering them something that they wanted.
Well, again, fantastic presentation, Emily. And as a reminder, this presentation, both the slides and the recording, will be available on our website, and everybody who registered will get that link. It's just a powerful testament to how impactful relationships are in interpersonal conversations. And when you look at how we change our practice, not very strong impact of reading journals, a little bit more, but still not very strong about sitting in a big CME audience. But certainly a one-on-one conversation that's very targeted with a well-trained person, clinician or not, is a really powerful tool. And so we encourage you to take what you've learned today and think about how it applies in your community. And of course, Emily is happy to answer any questions offline, and her email is in the slides, and you can also reach out to us at CHCF. So thanks again for spending an hour with us, and we look forward to the next webinar in May on maternal addiction treatment.
Thanks very much.